Now, without further ado, let us start with the next session on the agenda, establishing de-addiction services. I welcome onto the stage the chairpersons for the session, Dr. Ramana Cherkuri, Director, Asha Hospital and in charge of Asha De-Addiction Center. Welcome, sir. I welcome Dr. Pavan Kulkarni, HOD Telmada Anand Rao Institute of Medical Sciences, Karimnagar, and also the consultant psychiatrist at Sri Rama Hospital, Karimnagar. Glad to have you, sir. I now hand over the dais to the chairperson.
On establishing a de-addiction center. Based on my experience, there are mainly two components to this part of establishing a de-addiction center. The first part is relatively easy. Finding decent premises, recruiting and training the staff, implementing an effective treatment program, and of course, getting patients to fill the bed so that the project is viable. These are all relatively easy. This is something we do in our private practice anyway, and this is something we are trained for to some extent. The second part of knowing the regulations, complying with the licensing laws, knowing what to do when things go wrong, which they invariably do from time to time. This is an extremely difficult part, especially for the medical professions. As the chief guest was saying, there are several centers which do not follow any rules. They just dump whatever patient they can find and then run the place. That's something that we cannot do, and when we have to comply with regulations, there are so many of them, and to talk us through this maze of regulations and also in running the medical treatment in a de-addiction center, we have with us a very distinguished speaker, and I request my co-chairperson to introduce him.
Thank you. I take this privilege to invite Dr. Jagdish sir to the dais, and it's honor to introduce sir. As you know, the chief guest, Raghuram sir, was already mentioning Jagdish sir names. So sir has finished his MD from NIMHANS Bangalore, and then sir went on to establish departments of psychiatry at KIMS, and then Abhaya Hospital. And sir is a past president of IPS Karnataka chapter and also past president of IPS South Zone. And sir is also active, very active member at the national IPS level. Sir is the chairperson of the private psychiatry specialty section. So with this brief introduction, I invite Dr. Jagdish sir.
Thank you. Thanks for inviting me for this 9th MID-TERM CME of Telangana. Thanks to Dr. Ashok Alimchandani and the team. And today's topic is on establishing a de-addiction center. Thanks to Dr. Ramana and Dr. Pavan Kulkarni. Always liquor is served at the end, but I have been privileged to start with how to stop drinking. Not everyone who drinks is an alcoholic. If alcohol is a problem which affects their physical well-being, psychological well-being, family well-being, professional well-being, or behaving abnormally in the society, makes them to come back for treatment. So we have seen some people, especially in industries where even with a small drink, when they behave very abnormally, are brought for consultation. Today, there are two aspects. I'll restrict myself for 30 minutes and I'll be showing some of the things. There are three aspects when you start with to want to start a de-addiction center. As doctor said, one of the things is physical infrastructure. Second is about legal thing. Third is about manpower. Coming to legal aspect, I want to cut short and focus on what are the pains and pleasure of running a de-addiction center. Because all other things we can discuss. Yes, for example, most of the patients, especially if the patient is an alcoholic, are brought in different phases to the hospital. Either patient is intoxicated and brought to hospital, already patient had a withdrawal seizure and brought, patient had what you call delirium tremens and brought to hospital, and more so today we are seeing lot of patients get admitted to general hospitals like even a corporate hospital, Apollo, Fortis, whatever you say, Narayana, etc. Because once the immediate medical services are done, they don't want to keep any alcoholic patient in their ward. Immediately they say go to a place where there is a treatment available. So with medical complications they come to us. So this is one set. Second is about substance abuse. In substance abuse, there are two things we see. One, patient with violence. One, either
they are brought forcefully to the emergency ward to get treated for substance abuse related violence, or patients already having some psychological problems secondary to substance abuse and brought to the hospital. Third sector, the patient families come and request, doctor, he's so violent, we are unable to manage, I don't know what to do. So, budding psychiatrists, what legal aspects we have? So, first and the foremost, when the patient with such things come to hospital to you, make them give a sheet of paper, tell them to write down everything, what's the problem happening to them, and what is there any real violence towards family, towards self, or is there any harm to self, harm to the family members. Document it properly, and they give a requisition to the consultant, to the hospital and the director and the psychiatrist. After receiving that and going through history properly, what we can do is, we can issue a letter to the police stating that such and such a person aged was approached by the family, he is supposed to be having substance abuse with these behavioral issues, he is refusing to come for treatment, so he has to be admitted with a police support under section 100. They are supposed to go and bring the patient to the police station, not to file a case, help them assist in admission under section 89 and to the psychiatrist, so that the safety of the patient is taken care. In olden days, what used to do, you have seen in Hindi movie, send an ambulance with 5 people, they will hold him, put him down, give an injection, then they will tie him up and bring him to the hospital. So it was dehumanized. It was very, very inhuman way of projecting in the movies in those days. So today, we take the police help and also send the nurses along with the ambulance, etc. With their help, usually we, if required, sedate and bring them to the hospital. So this is one of the procedure. Second is about establishing a de-addiction center. One is about we have to follow the MHCA rule. Apart from that, every state has a mental health review board. So once that MHRB is established, that MHRB will put the guidelines. So for example, Karnataka is the first state to have a mental health review board headed by a retired judge, magistrate. So he is the head of the thing. Under him, there are other people, committee members, and they are nominated, all those things. They give advertisement, psychiatrists, social workers, family members, etc., etc. And a complete mental health review board is constituted. So we have to take the permission from the many centers, medical establishment, local laws have to be followed. Okay? So one has to be answerable to MHRB. So whenever a patient is admitted under section 89, invariably we have to inform them. MHRB, just information. So earlier, when the law was implemented, they said they have to come, visit, tell and all. It is practically not possible, so we have to just inform. In case they have any problem, doubt, they may visit us and find out, is there any other problem, otherwise the patient has been admitted under 89. Later on, if required, we have to shift from 89 to 86 or 90. So this is the admission procedure. One has to be extremely compliant with MHCA 2017, because there we should not be caught for violating the law. This is about the law. But now, what I wanted to share with the young psychiatrists, what infrastructure is required. Can we just go ahead?
The slide changes if you'd like.
Which one?
Say de-addiction center. All of you should know. I'll just take only 30 minutes because I'll cut short my talk. There are already doyens who are here, have established already a drug and alcohol treatment center or mental health care facility. So one doctor is also here who is also running. But I want to share how one can see. There are two aspects, as I told you. One is legal aspect, which I've narrated in a short way. Then we have to go for the next one.
It is not
Brought in different phases of illness in the de-addiction center. Second phase is, once that emergency treatment is over, then the patient is taken up for the detoxification. Once the detox is once his detox is over, patient will come for either get discharged, come on outpatient basis, or patient can come as a residential care. Then we have to have follow-up. In this broad category, we manage most of our patients. So why this is important. I just want to tell you, if you want to establish a de-addiction center, never forget to have an emergency care center, emergency care center, emergency care center. I just want to tell you one small incident which happened 2 months back. One doctor's son, aged 29 years, he was brought at around 5:30 a.m. in the morning, intoxicated. Immediately the duty doctor did everything, all those things. By 6, when he was shifted to our semi-ICU, like step-down ICU, by 6, the gentleman had a respiratory arrest. Because there was an ICU doctor, immediately could able to intubate and do that. And so we could able to save that young boy, 29 years. This is one of the extreme I am telling you. Other commonest is when they are brought to hospital, we have trained nurses to tell them, put it in a yes-safe position to see that invariably the other complication we have seen is they are brought totally intoxicated, drunk, with a half an hour back he has consumed, 1 hour back he has consumed. They want to, before admission they think, make him to get drunk so that easy to shift him to hospital. Aspiration is one of the other complication we see day in and out. The moment they are brought forcefully, etc., they just puke and they drown themselves. So these are many, and third thing is seizures. Just you would have had a seizure and brought to the hospital. Especially recently, one fellow had a substance abuse fellow, 5 o'clock had a seizure, 7:30 another seizure. So he was admitted to a nearest hospital, and by evening they shifted. When we interviewed, he had slurring of speech and sensory aphasia. I thought seizure related delirium is something different than what we saw. When we got an MRI, he had a corticovenous thrombosis. And a lot of patients, I can have slides etc. to show you today, young adults coming with alcohol dependence, dehydration, having stroke. So what I am trying to tell the young psychiatrist is, whenever a patient is brought, unlike psychiatric patients where they will have many more complications because they are brought in the different way. When it comes to substance abuse, violence is the first thing which they come. So the best thing, one of my doctor, he recently joined after passing out MD. The patient was brought 21 years, well built, 90 kgs. Every 5 people were holding and struggling to keep him in the casualty. I just told him, you attend to it, I'll come because I was seeing another patient. In his enthusiasm, he gave 10 milligrams of haloperidol mixed with 4 milligrams of lorazepam. Believe it or not, within no time the patient, I just went in 5 minutes, already BP was dropping to 50, 70 and heart rate was 170. Luckily, immediately I have to put a cannula and push that in a normal saline, and within 20 minutes the BP came to 90, heart rate came to 130. It took 2 hours to resuscitate the patient, and whole gamut of patients, relatives were outside. Why I am telling you is, when they are brought in such a violent patient, he did not know what to do because he was so violent, that boy. What I am trying to tell, I taught him was, the moment the any violent patient first you have a cannula, because that's the lifeline we have. Next, give the small dose. If not, we can repeat again. If not, we can repeat again. So let us not be too aggressive to start with dosing off the aggression of the patient. So these are all the complications which I keep seeing. Next, so whenever the detox takes place, the first on the this thing is always at least have something like a step-down ICU like facility where nurses are well trained, restrained, not to have the complications, etc. And watch for complications like aspiration, self-harm and fall. Because when the patient is sedated, we send him to ward, so they try to go to toilet, whatever it is, they fall. The moment anything happens inside the premises, the family blames the doctors, not them. They don't want to take the blame. Because they are not mentally ill. They are not physically ill. They say, we brought you for de-addiction and the patient has fallen head injury. So one has to be extremely careful during the detoxification, because nobody can calculate the dose and give, whether it's substance abuse or with the alcohol abuse. So one has to be extremely careful taking care of these things, aspiration, aspiration, especially aspiration and self-harm. Because during that period they can have delirium, they can harm themselves within the hospital premises. So then the fall, this to be taken care of. What are the special attention given? However careful we are, still there is a risk of seizures. And second is aspiration pneumonia. Third one is, what we see is, in spite of being at the earliest we start treatment, still a small percentage of patients can get into delirium tremens. And a couple of things which are forgotten, even when they are referred from a corporate hospital after 24-48 hours, I have seen 2-3 things which are missed. One is they may do liver function test, etc., etc. One commonest thing they forget is hyperammonia. If the patient is still having delirium, not responding adequately to your benzodiazepines or whatever drug you are giving, it is always judicious to do ammonia levels. And invariably we find at least 20% of patients having hyperammonia. And the simplest treatment is to give enema and acylactone, etc., etc. So third one is about electrolytes. Unless they are properly corrected, delirium doesn't come down. Cardiac evaluation is extremely important, and if required CT scan if there is a seizure, irrespective, that may be rum fit, but if we have seen in elderly patient having subdural hematoma and all after a fall. So one should be little more aggressive when the patient comes to de-addiction center, because they are not medically sick. The family thinks we are brought just to give up alcohol and not to stop drugs. They don't know the complications of it. So one should be extremely careful about this. I just want to tell the young doctors here, the moment patient is brought to the casualty, I have kept that one SOP for immediately to see that. First is GRBS. Many a times, yesterday one young adult, 42 years fellow, he's having, no, not 42, he was 29 years, 445 is the sugar, and the family says we don't know at all. He had pain abdomen on and off, and on further investigation we found he had pancreatitis, because secondary to substance abuse, alcohol. So his sugar was 445. So immediately GRBS, and once the patient is manageable, immediately we try to do ECG, because many a times ischemic heart disease is not picked up. For example, last week only I just saw one fellow, 41 years, he was volunteer, everything. When we saw echo, 31 was the ejection fraction. So medical complications are very high among alcohol and substance abuse patients. So X-ray chest, especially as soon as they come, once is little manageable, GRBS, ECG, minimal investigations have to be done, and especially never forget to rule out infections. So simple test of CBC will tell. If it is more than 10,000 of WBC, we should look for it. Elderly individual may have diabetes with urinary tract infection, other may have lung infection, other things and all. So one should be extremely careful about ruling out. Another commonest thing we are forgetting is not many intoxicated patients or patients don't tell about acute abdomen pain. Many a times even when we refer to physicians, they thought alcoholic means gastritis. Pancreatitis is another commonest thing which we are picking up. The best is to see that the SOP is there. You screen for everything, ammonia to serum amylase, serum lipase, electrolyte, CBC, apart from LFT, kidney function, etc., etc., etc. Next one, please. Your pancreatitis should have gone there. Then once he is admitted, especially in the detox phase, the fluids in the initial phase is very important. Many a times they come detoxified, dehydrated. In the Western society, if you look into American textbook, they say 5 to 7 liters of fluid to be given. Probably Indian patients, that will be overload. Minimum of 1.5 liters, 100 ml per hour should be maintained with always substitute, adding with B1, B6, B12. If you have B1, fine. If you don't have B1, B6, B12 has to be added, because we should not precipitate Korsakoff psychosis and Wernicke's encephalopathy. So fluids and nutrition, safety, and one more thing, please, every patient who comes for addiction, take a physician opinion, make that person to write the notes, because if there is any medical complication, it's easy for us to defend. When the patient came, patient had all these problems, that's why we have already taken the consultation. You should be mentally prepared. That's why we have to rule out vitamins, etc. Comorbid medical complications are the one of the things. History taking is extremely important. So comorbid medical conditions have to be kept in mind before we are going while treating the detox. Next one, please. So once detox is over, then we have, so that's why now I have, if someone wants to have a standalone drug de-addiction center, the phase is the most important. Make sure that medical care is good at the first phase, because as doctor was telling, you need a bigger space for de-addiction, because in a small place you can't keep a patient for 4 weeks, 12 weeks like that. So in such situation, patients get exhausted, they become violent, all those things is difficult. So if you have to have an establishment on the outskirts where there is a spacious environment where the patient can stay, then probably it is desirable to have a detox center in the heart of the city where you have all the medical facilities. Okay, so one should have either two. The advantage of having a detox and then our long-term care, residential care, one advantage is, okay, most of the patients when they are brought, according to MHCA Act, we admit them under 89, Section 89. Very few patients, when we sit and talk to them for an hour, most of them will give, some of them will give consent for 86. Okay, I am getting admitted. We convince them, probably you need 3 to 4 weeks, kindly cooperate with us. This is what we are going to do for you. Then they ask, I can do the same thing at home, etc., etc. All those things have been tried and failed, hence you have been brought here. Every patient will have the denial, okay, I can stop on my own, nothing has happened, all those. So, as much as possible, it is, if the patient is in census, motivate them to get admitted under Section 86. Half the legal hurdle is passed. Then, second thing is, we go to Section 89, admit them. In 3 days, nothing has happened. Patient is still there. Write to MHRB for Section 90. Transfer them to Section 90. Only the tricky issue is capacity assessment. Once the detox is done, every patient is fit to tell, thank you very much, doctor, I'm all right, I want to go home. Today, unfortunately, Mr. Ramesh Reddy Garu is not here. Otherwise, we could have, he's so enthusiastic. So we need such directors to bring it to the notice of the government to tell, don't equate de-addiction to mental illness. So that is one of the tricky issues of capacity assessment. Most of them will tell, I have the capacity, I know, please discharge me, thank you very much. So making a contract, etc., Section 90, all those things to be taken care. So what are the facilities you require at the center physically? One is, we need to have outpatient because there will be patients walking in, walking out. Every de-addiction center, that doesn't mean that any patient walks in, want to get admitted. There are a lot of patients after detox, they say, doctor, I understand, they come. You give them 2-3 chances, third time they get admitted. Write down today. First time, the one of our teacher, Dr. Santosh Chaturvedi was there. He was telling it should be like a revolving door. So allow them to come in, go out. After 5 times they say, thank you very much, doctor, I'll stay with you. Because establishing a rapport, convincing the patient is very important. Not that every time the patient has come, I'll pin him down, put him inside. If you do heroic, your intention may be good, but law doesn't permit. So one should be extremely careful about it. Second, patient facilities. Family counseling is extremely important. Consultation chambers should be there. And any de-addiction center, if it is standalone, we need to have a laboratory, pharmacy, laboratory for emergency. DRBS, then taking ECG, etc. Pharmacy is mandatory. Some general stores for the patients to have laundry, etc. These are the things we need. Next. So now there is a discussion going on. Lot of patients, especially urban, a lot of them come and tell, doctor, I don't want my daughter or my wife to be admitted with other men. Because problem in drug addiction is, and substance abuse and alcohol is, some of them can have what we call cluster B personality. So they are the one which are difficult to handle, especially among the women. What our experience of our team who work, they say, sir, do whatever you want. Ground floor is men, first floor is women. All you have, when they want to go out, the easiest is to tell, this fellow touched me, he sexually tried to abuse me. Enough, that one police complaint is enough to run behind everybody. So that is where now the biggest challenge of keeping men and women together, because if they are many manipulative, I'll tell you, they make our lives miserable. They make our lives miserable. When a married or a single woman, unmarried, divorced, whatever it is, admitted, some other fellow will come and tell, why you have kept her here? So I know her very well, I will take care of her. The family wants her to be treated. Some other third person who is not nominated representative legally will come and argue, bring the media, she has been detained, all those things. So one should be extremely careful. So now you have to decide how we can keep men and women together, what precautions have to be taken, or should we, now so many lady psychiatrists are coming out, would they like to have a exclusive female or a male de-addiction center? combined with third setup in a de-addiction is, some of them, it's going to be extremely costly to maintain the manpower for only de-addiction. They combine with the psychiatric patients also. So there will be only thing, when such things are done, there are some people who bring out the objection that my patient is not mentally ill, doctor, why do you want to combine with them? Because they need a separate therapy also. So in that context, we should have a separate ward and a separate unit and a separate program for them. So what are the manpower? Now coming to the manpower, MHRB in Karnataka, we are working on that. How many doctors should be there for how many number of patients? So initially it was thought 30 for 30 patients, one psychiatrist. Probably in many places it's not possible, so they have extended to 50. Then for every 10 patient they wanted a nurse. They said they are not acute patients. After detox, they are sent to residential care. So we have made it now 30. For every 30 patient, there should be one nurse. So for practically you need 3 nurses, because 3 shifts for 30 patients. So if you have a 50-bed de-addiction center, you will have 10 to 12 nurses, because when they give day off, etc. and all those things. Then we need a team of psychologists. Many a times you may not find as the manpower he was telling, doctor was telling, so we may not get ready-made MPhils everywhere. So we may have to take freshers, train them and post them into all those things. Then social worker is extremely important in handling legal, family, their occasion, etc. Today, even in our Karnataka thing also, they said, appoint yoga therapist, even MSCA. Hare, what is the cost? See, it's just keep on adding. What I have done is, we have male nurses. I have sent them to Vivekananda Yoga Kendra in Bangalore, certified them as yoga therapist of 3 months training, and they are doing the simple thing, because they don't need, all Patanjali said they don't need. They need some simple exercises, because I have all the slides. I don't know whether he has loaded or not, my friend. Simple exercises, because they may not be able to do all asanas what they describe. And nursing care. Nurses have to be extremely sensitive. They have to be trained in 3 aspects. 1, watch for the medical complication. 2nd, maintain a communication with them. 3rd, they should be the liaison between family, patient, and the doctor. When the patient family comes, how the patient interacts with them. They may be very polite with us. When the family comes, they will be extremely hostile. So all these things will be communicated to us through the nurses, because a psychiatrist cannot keep watching all those things. Pharmacist, dietitian, because diabetic, hypertensives, lot of medical complication, liver cirrhosis, early phase, all of them get admitted. So dietitian is also important. Lastly, if possible, a rehabilitation counselor. Otherwise, the psychiatrist, duty doctor. Yes, coming to duty doctor. This is one of the biggest challenge. Luckily, still they have not banned other medical professionals like Ayurveda, homeopathy, Unani, etc. to be trained and work. Only thing, they have to take instruction from us and implement it, rather than independently prescribing. Clear? So that we may not get MBBS doctors, nor a psychiatrist round the clock. So one should be extremely careful about doing this. Next one, please. So patient housing facility. This is what I was just telling. There are emergency treatment room, I told you. Apart from detox ward, we should have an emergency ward. He has not shown ECG, GRBS, one pulse oximeter, this thing, oxygen, just like a mini boils operators, etc. Nebulization is the another commonest thing. Suddenly, early morning, he will start having wheezing, etc., allergic patients, all those things. So minimal care of emergency should be there, and in case of further emergency, take an undertaking should be shifted to nearest general hospital. So they should have adequate facility for ventilation, and we should not be crowded, and they should have a hall for yoga, they sit for entertainment, then they can have general ward, twin sharing. One of the best thing which can be done, even initially when I started, that was my idea of requesting family members to stay with the patient. Half the burden comes on, though it's a double-edged sword, their expectations are different. The moment they think a patient is admitted to de-addiction center means it's like a military regime. He gets up, he does 24 or some 8, 12 hours, some schedule, tight schedule and all those things, like a semi-military regime, which is not true. So their expectations will be different. We have to counsel. If a family member stays with the patient, definitely it's going to be beneficial. If you think of TTK, without a family member, no patient is admitted in Chennai, TTK. Only thing, extremely difficult. All of them tell, sir, we are unable to take care, that's why we brought the patient, please take care. Majority don't want to stay, but we tell them to keep frequently come and give the phone connection. And sometimes if they are from a far off place, video call, so that document it. This patient was allowed to speak, this patient has spoken to them, so that tomorrow when some inspection comes, no sir, I'm in a jail, they have not given any communication, I don't know where my family is. They can give a big list of complaints to just go out. So we have to maintain those things. Next. So adequate space for what is our de-addiction center, I'm just showing you. Big quadrangle inside so that they cannot run away till detox etc. is done, and then only they are left outside to play and all those things. So in recreation inside, all are required. Next one. So activities have to be semi-structured. It cannot be a structured one like a military regime. Usually it starts by 6:30, 7 o'clock and goes on till both individual and group therapy. Group therapy is mandatory, group therapy is mandatory. And having family therapies, especially addressing the spouses and all. Every day if we have 50 patients, 5 to 7 families per day have to be invited. Invariably, Saturday or Sunday, lot of families will come. We tell them to come because we can have a group meeting of the family members, can address their concerns, and many a time senior patient's wife can tell 3 times my patient or my husband was admitted, this is what I did. So that self-help also will help in a group meeting weekly once of the family members. And if the children also have some, for example, I'll just give one small example. A leading ophthalmologist in Tier 2 city of Bangalore, India, Karnataka, extremely successful man. Every day minimum 15 cataract and 70 patient he sees, and very competent fellow. He will drink and fall in the hospital. The 12th standard girl and 10th standard girl, 2 daughters, they said, we don't want to live with our dad. Very clear. He has built a palatial house, but they have taken up a rented house. Wife and children are there. It took almost 5-6 sittings to integrate them back into him. It's not going to be so easy. Today children are very smart. They just say, thank you very much, we want to walk out. So taking care of children is also extremely important. Another one thing which are not totally exposed to self-help groups while we are doing post-graduation is Alcoholic Anonymous, Narcotic Anonymous, Al-Anon. What happens? If post young adults, every city has that AA meetings, NA meetings are there. On one day, especially on Sunday, it's a family meeting. Another midweek will be some one of the relative can go or something like that. So one of these family meetings, if you people can go and sit for 3-4 sessions, you will learn what happens in AA meeting. Extremely helpful in many patients. Narcotic Anonymous, once he is relapsed, another patient will bring, sir, he was doing well for last 3 months. Suddenly again he started with ganja, doctor, please help him. So a recovered patient helps the other patient. So never ignore Alcoholic Anonymous, Narcotic Anonymous. Al-Anon, I have seen very few in Bangalore. Again, I don't know how to tell, double-edged sword. Sometimes they say in terms of empowering the spouse, they make them rebellious. Entire therapeutic process is gone. She becomes a lady who was always listening to everything and very courteous, suddenly becomes very rebellious. This fellow thinks, what happened to my wife? And he becomes, okay, you are behaving like this. Thank you very much. I continue to drink or take drugs more. So it's a double-edged sword. Though we have to empower, but it should be a balanced one. What all I have seen in my last 30 years, I am talking to you people, please understand. So AA meeting and in the de-addiction center, every day having a AA meeting is extremely important. Make them to read the big book and also follow the 12 steps. Make them to write. Okay, there is a power above me which is superior, so I confide. Then taking moral inventory under intoxication or whatever, it applies to both drug and alcohol. Who are the people who have been affected by my behavior? I try to mend, I try to confide, I try to apologize, and every day I try to correct myself. These are really, really, really helpful. Once they get inside and you make them to start writing and introspect, definitely this transforms. Let us not stick to one school of 100 CBTs and etc. These are also equally helpful whether they are literates or illiterates. Next. So relapse prevention is another thing. You have treated a patient patient got discharged, patient has gone home, many people are bound to relapse within 3 to 6 months. So in that case, we need to have a separate program. Combining a patient 4 times relapses and get back to the new patient, sometimes it is demoralizing for the new patient. Oh, I will also not recover. This fellow is coming all the time again and again. So preferably, we should have a short stay for relapse prevention. See what factors contributed for his relapse every time. Address that effectively, and frequently calling them on outpatient basis can benefit them rather than frequent admissions. And admit along with other patients is the question. Short stay and separate intervention therapy. Next, please. What are the types of addiction? All these things. So especially, you have seen all these things. What are the one more thing I see is whenever a patient is brought from Maldives, God, it is cocktail. What all drugs they are using? 3 to 5 days in severe delirium. Any foreign national is admitted, please immediately report to FRO, Foreign Registration Office. It's our duty to report to them with the passport number, such and such a patient has come. Because we see from Bangladesh, Pakistan, not Pakistan, Sri Lanka, and mainly from Maldives. Lot of drug addiction. So one has to immediately report to them, take all the consents, and they are really challenging. It's not one drug and not picked up by everything, and they will be invariably in delirium, 3 to 5 days. And it's a hell, because one is foreign national, second, only one family or a friend would have accompanied them along with them from Maldives, and it's really a challenge. So one has to be extremely careful when it's a polysubstance. Next. So as I said, it is some of the, I have another, just 5 minutes I'll finish. Apart from today, in the de-addiction center, because they have not told, they have made it as de-addiction program. So the 2 challenging things which are adding up to substance abuse and alcohol is pathological gambling. Pathological gambling. Crores lost, the lakhs of rupees, household, still that fellow is unable to give up. They are even from Hyderabad, the parents are well-known doctors. Doctor said the son is also a doctor and a postgraduate. One fine day they asked, what happened to the car? He said, my friend's wedding, so I have given the car, after he will give. 3 months car did not come back. Similarly, they saw money is disappearing, etc. After some time, they realized they have sold everything, and because there are so many apps today, one can take any amount of loan and only they will come and talk. Recently, one fellow has probably 6 to 7 crores he has lost, and father was one of the contestant, lost MLA election, and now for a MP election he is one of the candidates. And when he did not pay and he was admitted in a rehab, they could not trace him. They can't do coercion according to law. So they write very badly in the social media. They have put up that fellow is a pimp, he's running a prostitution center, about the father. Sitting in somewhere in other countries, they keep on posting such vulgar and postings on the social media to pressurize them to pay. And give them, again he will go back to that. So pathological gambling is another biggest challenge coming into de-addiction. Second is about screen time addiction. Screen time addiction, above 18 only we are admitting, below that no. Invariably most of them will have other issues like ADHD or ASPD, etc. So we have to address those things. So one of the other thing about de-addiction is pathological gambling. So we need to address all those things. Next. So invariably 3 to 4 weeks is good for an alcohol patient unless they have a comorbid medical condition or a comorbid psychiatric condition. If they have really a disabling comorbid medical condition, because what all the things in last 2-3 months I lost patients. One is hepatorenal, went into failure, 48 years, even in the best center we referred, he passed away. Hepatopulmonary, so patient was not able to even walk 10 feet. So gradually he improved over 12 weeks. He's a class 1 officer in government of Karnataka. Hepatorenal, and patients having CNS complications. So they are the people, and early cirrhosis. So during that period, invariably they agree to stay back for some more time. So they are the people where we extend the stay for 12 weeks. In coming to substance abuse, invariably marijuana alone patients will take much longer time. If they have associated comorbid psychiatric illnesses, we need to classify under that and extend their stay by using that section 90 up to 3 months and extend, but we need to document properly in that patients. So if they have severe comorbid conditions like schizophrenia, bipolar, any other psychotic symptoms, they can go. And we have seen some of the common Korsakoff psychosis is another patient as brought from US, 52 years. With great difficulty, he could able to reach India. And his sisters are all doctors. One is practicing Hyderabad, one is in Chennai, etc. He's taken almost 3 months to improve little bit. And we have put him into cognitive retraining at Nimans. Still, it's going on for 6 months. Some patients, they give consent to stay for a longer stay. Otherwise, on an average, 3 to 4 weeks for alcohol, 4 to 12 weeks for substance abuse. Next. So self-help group, as I told you, AA, NA, Al-Anon, Alateen, all are important. Next one. So one of the things, so medication, when it comes to medication, it has to be monitored by the staff, which is very important. One is, all of us know, patient will take it, throw it in the basket, etc., etc. But what I have seen, some of the patients who are very intelligent are collecting all the tablets. Suddenly one fine day, they swallow everything and patient is not waking up in the morning. He says, I want to get discharged. That's all. Means suddenly you know what you, then you would have taken drug overdose. He would have kept all the 5 days drugs and taken one time. So make sure that patient is taking tablets on, that's what some of the patients which I have seen, collected tablets and did. We trusted, anyhow this patient is quite calm, so he will take it, and so one should be careful. Next. What is, there is no set model for recovery. If a person, at least for 1 calendar year, if he remains abstinent from drugs and etc., especially young adults between the age of 18, 20, 25 and all, when they come with polysubstance abuse, it is desirable to keep screening them when they come for follow-up for the drug addiction. Out of 3 times, at least once or twice they would have taken, but they claim, doctor, I have not taken. It is better not to reprimand, but we have to understand, and therapy works with them. So screening is extremely important. Any person who remains abstinent for 1 calendar year, usually the outcome is better. We also feel a patient has gone discharged after 3-4 months, 1 drink or 1 time he takes some substance, he comes back, doctor, I should not have done it, I have done, please help me. That also is part of recovery. Means the patient has gained insight. I need to seek help, I should stop at this early. So even that can be, these are not given in the textbook. This is what I have seen in my practice, I am just sharing with you. Consultation at the earliest after relapse is one of the things I consider as a recovery. And then they are getting integrated into family, getting back to profession, etc. will gradually take some time. So counseling has to be competent, empathetic. We have to train them. Because burnout is common. Easy to treat with a mentally ill patient. We can ignore, etc. Here, once the detox is done, invariably they will have personality issues or normal people, empathy, all those things. And they should not treat them very badly. Hey, go and sit. No, they have to be extremely polite. You see good, bad and ugly patients. The best therapy to control the most violent patient is 3 ways. 1, if he is unmanageable, medical treatment. 2nd, the best treatment is time out technique. Just keep him off from all the things. No one should talk. He will just, when he is hungry, he will go for breakfast. When he is hungry, he will join on his own. Time out technique make many patients to come back to the stream within 3-4 days or 5 days. And lastly, still if it is
Dr.
not
Jagdish.
possible, use the finishing. Group therapy and break them. Last. So violent, aggressive patients are finished. Next. So this is all in a de-addiction center, how we are managing. So having it in a 3 acres campus. The first thing is in the, what I served was in my main hospital in the city. Once after detox, patients consent, we transfer them. With this, I'm extremely thankful for Telangana people to give an opportunity to share what I have done in the last 3 decades. Thank you very much. I will appreciate if there are many questions on this.
Thank you, sir. Yeah, the forum is open for questions.
It's open for questions, anything. Yes, sir.
On these addiction centers run by people who have recovered from alcohol
Yeah.
dependence themselves.
If there are 5 centers run by psychiatrists and mental health professionals, there are 95 run by the recovered patients who are not following any norms. In Karnataka, we have brought them into the mainstream, training those people, how they should be doing. Violence should be minimized, but many a times, even when we are helpless, they take them and all. Some of them liaison with a psychiatrist. That is what Mr. Ramesh Reddy Garu was also telling, that we are trying to bring them. Doctor was our CEO was also, Umashankar Sir Garu also was telling the same thing. In Bangalore, what we have done is, we are now conducting training program to those people. They are now reforming. Though if all the MHCA guidelines are implemented, they can be closed overnight. Yes, sir. Cheppin correct and thank you. They are licensing with a psychiatrist. Every week I see from each de-addiction center, 5, 7 patients are brought. We assess, give them medication. They are licensing with us. Because this has all happened after training those people. Always a recovered patient thinks, I can do better, which is not true. Emotionally disturbed person should never work with an emotionally disturbed patient. And many of them will be taken. Yes, sir.
Sir, I am Dr. Satish.
Yes, sir.
Sir, in your de-addiction centers, do you use anti-abuse?
Everything, sir. Medication I did not touch because they are all taught in the medical college. So it all depends. If the patient doesn't have CNS complications, seizures, if the patient doesn't have psychiatric illness like schizophrenia or major mental illness, if the patient doesn't have other medical complications, we don't mind. Because if he has a cardiac problem and disulfiram is given and if he consumes alcohol, the risk of death is very high. I have seen patients who are brought dead also. See, one patient has recovered, some lower middle class, and the neighbor lady asked, my husband is also drinking like this. Akka, don't worry, please powder this and give every day. One fine day at night when he was intoxicated, given and brought almost. So we always educate, take signature, and the philosophy behind giving disulfiram is educate the patient, take the signature. You want to stop drinking? Thank you very much. I am giving a tablet every day, which you should take a oath on yourself. As you wake up in the morning, you take 10 seconds on pray. Oh God, let this day be a good day. Similarly, spouse will give the tablet. I am not going to drink. That's why I am taking the tablet. If you convince and take signature and give this model, it works very well along with anti-craving medication.
Dr. Naresh, sir.
Because the theme of this conference is establishing psychiatric services and mainly for the upcoming psychiatrists.
Yes.
So that question is based on that. Is it possible to establish the de-addiction center which is financially viable with maintaining the standards of MHCA and being ethically practiced?
Thank you very much.
That's what they want.
Yes, last week one person has come and sitting with me, come back from US and wanted to start. After calculating the price of 3 acres of land outskirts of Bangalore and also this thing, then calculated and said, okay, doctor, let me see. Then he told me, I have a property of a 50-70 site inside Jayanagar, heart of city, what I can do. I said, you can start in a small way, daycare center with some 10 beds. You can definitely do it because that's very possible. May not be too long, 3 to 4 weeks with all the things can be done. Financially, if one has to get into it, definitely no. Years back, we bought the property, etc. It's feasible. Otherwise, no.
Sir, I have a question on myself,
Yes.
sir. Take
Every state has their own. Karnataka has many licenses, including Directorate of Medical Education, this thing, Health and Family Welfare, Establishment, all those things. MHRB, we have to register, and the guidelines of what manpower and what should be the space, etc., is getting finalized. As I told you, no, they wanted initially for every 10 patient, 1 nurse. We said no. So they made it now 30 patients, 1 nurse is enough. In a de-addiction, we don't have that. But in a detox, that's a different issue. Second thing is about manpower. They wanted for every 30 patients, 1 psychiatrist. We said in type 2 cities, there may be 50, 100 bed, especially Shumaga, etc. and all. How can they have 2 psychiatrists? In the entire town is only 1 psychiatrist. So we went up to 50. Like that, each state is working on. Then the psychologist stood up and said, no, there should be a qualified MPhil only. I said, just because you're unemployed, you can't impose on this. Thank you very much. Any BSc, MSc, all these are more than enough because we train them. Where do they get in tier 3 cities of MPhil people? Who will go and stay there? So all these are getting refined, and we are in the process of coming out with servants, how many class 4, what are the infrastructure. We are just working on it. because I am one of the committee members from the private sector. Government is giving much.
Ashok Reddy, sir.
Cheppanda, sir.
Medicines which are advertised and sold through TV advertisements.
Yes,
Have
sir.
you gone through them and found out
Sir,
what it is and
that's what
how to?
yesterday
it is
also.
like a menace.
Yesterday also, when I entered the room and the TV is automatically on. ఈ మందులు తీసుకుంటే మీరు తాగేది లేదు. దట్ వాజ్ అడ్వర్టైజ్మెంట్ కమింగ్ అండ్ నేను తీసుకున్న తర్వాత ఇదంతా బాగా అయింది. సో దిస్ అడ్వర్టైజ్మెంట్ వాజ్ గోయింగ్ ఆన్ ఇన్ ద టీవీ again and again. Some people have found that disulfiram is mixed and given. In some of them we have not found, but still they have abreaction when they consume alcohol. But for just for the upcoming doctors, see the drugs which you have to combine judiciously. One of the either you can use baclofen. In America, naltrexone is number one. If you go to Europe, acamprosate is number one. And people who are hefty and other things, obesity, topiramate works better. In Indian context, most of them come under nutrition. So one should be extremely careful with the topiramate because that brings down the appetite further and goes down. So one should be judiciously use anti-craving. Another, if the patient is fit, combining anti-abuse, that these two combinations work with them. When it comes to drug abuse, okay, one of the things, though for only opiates, extremely good, though buprenorphine is given, but naloxone with buprenorphine combination is extremely useful, and if it is given properly, outcome is extremely good in that. Next comes is cocaine. Though they say disulfiram works to certain extent, nothing. When they come with mainly with marijuana and other things, we focus on one is detox, second is to quit smoking. So use bupropion and other methods and motivate them and put him into NA cycle. Otherwise, we don't have a magic wand. Okay, this drugs make the patient better.
Thank you, Dr. Jagdish.
Yes,
Wind up.
Sir, one question, sir.
You're told with the organizers to.
Chapanda.
Sir, after admitting the patient, and we will give the all kind of services to the patient, some of the patients, family member will left out the person into the de-addiction center. What kind of precaution we have to take and how to deal in such cases, sir?
See, in the private sector, invariably they pay and do. A lot of patients pay, a family doesn't, de-addiction center without an advance, they don't admit the patient and all. Once it is done, usually done. Otherwise, take the consent of the patient. Patient is willing to get discharged, 86, under 86. He has the right to get discharged under 88. Take signature, drop him at home. That's all. There ends the matter.
Two more
Thank you,
comments
sir.
from Dr. Brahma
Sir,
and Dr.
Brahma, sir.
Keshara, then-
Yes, sir.
Sir, you're talking about the clinical psychologist
Yes, sir.
and MPhil. So,
Yes.
because I'm also a part of Rehabilitation Council of India as a council member, so every time in every meeting I'm talking about this. There are so less number of clinical psychologists or MPhil in our country on the whole. So, what do you think? How IPS, Indian Psychiatric Society, can influence RCI? Because many psychologists from my own state, they are requesting me, or from East Zone also, they are requesting me, sir, you go to the RCI meeting and you tell about this. Because in rehab center, what I found, this posting of psychologists is very important. So do you think just training of other psychologists is sufficient enough, or we need the clinical psychologist?
Sir, clinical psychologist is excellent for CBT. The
Yeah.
quality of work they do, especially patients who are not routinely improved, will do extremely well with them. That is important. So that comes as a tertiary care. The primary, even a good nursing care is enough. Secondary, BSc, BA, MSc. Now the government of India have said, there are confusing reports. They want to abolish MPhil. They want to make BSc psychology for 4 years and give them the right. So RCL will become redundant because they are strict. The small group are holding others in captivity, which will not last longer.
Just one last comment from Dr. Keshara.
Yes, sir. I am telling you this, sir. 4 weeks is most of the alcoholics. Others, drug addiction will take 4 to 12 weeks. We send them for now.
Thank you very much. We'll end the session now.
Thank you. Thanks for giving me an opportunity. It's a great pleasure with so many doyens, stalwarts who are all running are here. I was just wanted to talk to young colleagues, sharing my thanks. Thank you very much for Telangana Psychiatric Society for the opportunity. Thank you.
Thank you, sir, for your expertise and insight. I request the chairpersons to present. I request the speaker to present a note. A memento to Speaker Dr. Pavan Kulkarni, sir. session is on establishing child psychiatry services, for which I invite onto the stage chairpersons Dr. Ram Subba Reddy sir, Professor of Psychiatry, Nilofer Hospital. Welcome, sir. Dr. LVR Ushara, Professor of Psychiatry at Institute of Mental Health.
Good morning, everyone, and thank you for giving the opportunity to Dr. Ashok Kalim Chandani sir for this session. Now I invite our today's speaker, Dr. Gauri Devi Garu, to come over to the dash. The child psychiatric clinic. Unlike adult psychiatry centers, this is establishing child psychiatric clinic is completely different because of the overlapping of symptoms in child psychiatry and because of the heterogeneity of the presentations in the child psychiatric disorders. Multidisciplinary approach is necessary to address the problem.